Let's go a little further and talk now more generally in terms of formulary. So let's start here. At Memorial, who recommends products for the formulary? How does it work?
So when we have a new FDA-approved agent, or soon to be FDA-approved, it would be our specialist medical oncologist. So like Dr. Matazar working in his area in lymphoma, he or one of his colleagues would request addition of this agent to the formulary. They then work with the clinical pharmacist to develop kind of a form that we go through all the clinical efficacy and safety data, anticipated number of patients that we would treat in the context in which we would use these agents. And this is then presented to the P&T committee to give them an opportunity to ask questions, the other medical oncologists, the administrative staff, regarding logistical issues with pharmacy prep work and that sort of thing. But it's generally a collaboration between the medical oncologist, the clinical pharmacy team, and then our chemotherapy guideline committee and P&T.
What criteria do you guys use at Memorial then to put something on the formulary? Does it have to be better than what's already exists? You know, how do you guys usually work it?
So it doesn't necessarily have to be better per se, but the context in which it's used needs to add something to the patient's options. So, for instance, for multiple myeloma, we know is an incurable disease, right? So we're having relapse after relapse, right? And we need to have agents for patients.
But they have like ninth line therapy in myeloma.
Exactly, exactly, and
right.
That's what we're seeing with those agents. And actually, daratumumab is another subcutaneous formulation that's soon to be coming, right? So that one I see. No issue incorporating it within these relapse refractory settings. So it doesn't necessarily need to replace anything per se, but should add some benefit.
So do you guys take into account the route of administration then and the chair time? Is that all put in the P&T kind of deal or not?
I would say that the P&T committee at Memorial is effective because it has this sort of co-leadership by physicians, by pharmacists, and by administrators, where they can sort of look at an agent holistically and say, is this adding value to our patients? Okay. Pricing, quality of life, outcomes, toxicity, alternative options, what's it going to replace? And they can look at it sort of in the context of the disease state for which it's intended to decide whether this belongs on our formulary.
So the next question kind of is, do payers have anything to say about this? Do you ever get a payer saying, I want you to give sub-Q and not IV? Has that happened yet?
So yes, the IV formulation has its FDA label and it has its NCCN compendium listings. Right. And there are some clinical situations that fall technically outside of those defined parameters, but clinicians may still want to use in those settings. When one attempts to prescribe subcutaneous rituximab outside of those parameters, it usually creates a conversation with the payer. And you will have to explain the clinical rationale and why you want this to be done. And sometimes that conversation will lead to approval, and sometimes it will not.